welcome to another episode of Keeping London Healthy. My name is Dr. Elia. We've got a couple of great interviews for you today. There's been so much focus in the news about protests and mandates and vaccines, and it's really been kind of distracting, really, for many of us. And I thought it'd be really important to get back to talking about the actual medicine when it comes to COVID and remind us kind of why we're all doing this. So having two guests on the show today. First, we'll have Dr. Michael Khoury, who is a professor of pediatrics. He's a pediatric cardiologist at the University of Alberta. He'll be talking about COVID and the COVID vaccines and the effect on heart health. And then we'll be talking to Dr. Rob Leeper, who is a general surgeon and a critical care doc, an ICU doc, here at Victoria Hospital here in London. And he'll be talking about what it's like in the ICUs right now in London with regards to COVID. So looking forward to these interviews, and we'll be right back after this message. All right, welcome back. So as we mentioned prior to the break, I'm happy to have on the show today Dr. Michael Khoury. Dr. Khoury is a assistant professor at the University of Alberta, Department of Pediatrics in the section of cardiology. So we're happy to have him on the show today to talk about COVID and vaccine and cardiac related illness. So thanks again for joining us today, Mike.
Yeah, my pleasure, Mario. Thanks for having me.
So as I've mentioned on previous episodes, one of the cool things about having the show is I get to bring on specialists who I look to for advice and look to for guidance. And Mike was actually another med school colleague of mine. So it feels like we're going, like every episode, we're finding some med school classmate of ours that we can bring on. So Mike is our pediatric cardiology guru. So Mike, one of the reasons I wanted to chat was just to talk about, again, the impact of COVID and talk about the vaccines too, and the impact on heart health, because we're kind of seeing that, with regards to vaccination, the 5 to 11 age group, things have kind of plateaued. I've seen even in my numbers here in the practice, where whether it's 50%, 60%, and we're not really kind of seeing that uptake that we saw in older age groups. And just speaking to people in practice, one of the things that really seems to be of top of mind for parents is the issue of heart health, and they're worried about what's the impact of vaccines, and they're hearing about myocarditis and things. So this is one of the reasons I wanted to bring you on. So first, I guess we'll talk about the impact of COVID that you've seen in children with regards to cardiac illness. So what's been your experience there, Mike? I mean, this is COVID, not the vaccine. We'll talk about COVID first.
Sure. Yeah, I think off the bat, it's important to define some things, and so that we can understand what it is that we're talking about when we speak of COVID impact on heart health in kids. So the myocarditis is a big term that's thrown around, and it's a lot more people have become aware of the term myocarditis. Myocarditis basically means inflammation of the heart muscle, and it's a rare occurrence in general, something as pediatric cardiologists we commonly see because we see rare things that happen. And myocarditis typically happens after a viral illness, and COVID is no different. So if the body becomes infected with a virus, sometimes that virus can invade into the heart muscle tissue, and the heart muscle can become inflamed, as just like other tissues around the body can become inflamed. And sometimes, to various degrees, the heart can become quite sick, and as a result, the patient or the child can become quite sick from this. So COVID infection can definitely cause myocarditis. Thankfully, we haven't seen a lot of cases of severe myocarditis related to the COVID infection. What we have seen is something called MIS-C or MIS-C, and that stands for Multisystem Inflammatory Syndrome of Childhood. And this is an inflammatory disorder where the full body, including the heart, becomes inflamed a number of weeks after a COVID illness. So not directly related to the infection, but the kid gets over the infection or at times doesn't even know they had it. And then a number of weeks later, they get MIS-C. And this is something else that people often talk about. And this we've seen a lot more of. And unfortunately, we've seen children become quite unwell from this, with a lot of them ending up in the ICU. But thankfully, the vast majority have made complete recovery. So those are sort of the two, when we think about heart health in COVID, those are the two things to think about: myocarditis from the infection and then MIS-C that happens a number of weeks later.
And one thing that I've seen asked and stated as well, is this only kids with comorbidities like other medical issues, or have you seen MIS-C in kids who are otherwise completely well?
Yeah, MIS-C does not discriminate. So kids have had MIS-C with a very wide spectrum, and also a wide spectrum of age and sex, and presence or absence of comorbidities. And while children with comorbidities, and I'll get back to that in a second, seem to maybe be at a higher risk of a severe outcome when we talk about scary things like death from MIS-C, children who have been previously completely healthy have also had severe outcomes, like needing to go to the ICU and needing IV medications to support their blood pressure and things like that. But I also think it's important, I'm sure you've mentioned this many times, is that a comorbidity is not a rare occurrence. Many of us have comorbidities, and this is not sort of a set of others who are particularly sick on a day-to-day basis. Comorbidities are things that are very common in our day-to-day life, like asthma or obesity, which makes up a significant portion of the population.
Have you seen the numbers of cases of MIS-C track with waves? And the reason I ask this is that we've seen so many kind of point to, well, are those hospitalization numbers and those pediatric numbers people with versus of COVID, and are they just incidental diagnosis in hospital, where we know that's not the case, that there are cases due to COVID. Again, have you seen the MIS-C cases tracking pretty well with the size of the waves as we've gone along?
Essentially, yeah, there's been a lot of interest in sort of the academic literature of trying to define whether or not certain COVID variants are more or less associated with the development of MIS-C. In the end, I think there needs to be more work done in that area. In general, when we have seen a spike of COVID cases in our community in Alberta here, then the writing has essentially been on the wall that in about 4 to 6 weeks' time, we will see a spike of MIS-C cases. And they generally have followed in tune. Thankfully, MIS-C is a rare complication from COVID, but it still is common enough that it occupies a lot of our hospital beds. Absolutely.
So we'll shift over to the vaccines, because we talked about parents before and kind of what they've heard from people and what's kind of played into their the decisions they've made. And they've heard from somebody who they had myocarditis from the vaccine, and that's led them not to get it. So what's your experience been, kind of as a pediatric cardiologist, with what you've seen from the vaccine and myocarditis? What's been your experience?
There definitely is an association. I think it is. It would be unfair to say otherwise. There is an increased risk of developing myocarditis in the days after receiving the mRNA COVID vaccinations, which are essentially for us in Canada, Pfizer and Moderna. And when it comes to children, it's just Pfizer, because in the vast majority of locations in Canada, the Moderna vaccination has now been restricted to individuals that are outside of the pediatric age range. Now, we need to look into the data a little bit more and see who is specifically at risk. And bar none, the highest risk individuals are in the pediatric age group are adolescent males, particularly those aged 16 to 19 years of age after their second dose of the mRNA vaccination. Interestingly, here at our center, and of course the numbers are always small because this is still, it's important to emphasize, a really rare event. But at our center, we haven't seen one girl develop myocarditis after the vaccination. And in most of the published literature, it's well over 90 to 95% of the myocarditis occurs in males. So it suggests, and the vast majority of them are after puberty, so later in adolescence. So it suggests that perhaps there's some sort of hormonal explanation or something to explain this, but I don't think anybody fully knows why this is occurring in males. So if you look at this high-risk group of the 16 to 19 age group, it's important to emphasize that the risk is still about 1 in 10,000 people. That's from Israeli data, which has probably been the best surveillance data, but American data has sort of supported this as well. So we've seen about 1 in 10,000 individuals have developed myocarditis in this 16 to 19 age group. Now, Mario, at the beginning, you talked about concerned families that are in the 5 to 11 year age group. And what we fortunately have seen in our surveillance across North America is hardly any cases of myocarditis in those younger pediatric age groups. Personally, here in Alberta, I don't know of a single case yet, but across Canada, from my colleagues, we also haven't heard of any vaccine-associated myocarditis in the 5 to 11 age group, and really not many at all in the 12 to 16 age group as well.
Have you seen more with Moderna than with Pfizer? I know that's part of the recommendations for why we're not giving Moderna anymore to anyone under 30. Did you see much of a difference between the two?
So I can't really speak personally to the Moderna risk because it was never really that available. It was available at the beginning to some of the pediatric age groups, but it's not been enough to really personally speak to that. But the data definitely suggests that. The data definitely suggests that the risk of myocarditis in young adolescent males and young adult males is higher with the Moderna vaccine compared to the Pfizer vaccine. And so NACI, the National Advisory Board, has responded accordingly and has recommended the Pfizer vaccine for adolescent males.
Correct. And I know I always like asking other physicians kind of what they've done with their own kids with vaccination. My daughters are too young to get it, but I've told people if they're old enough, I would give it to them. I know you've got kids, Mike, and your decision around vaccination has been.
Yeah, so I have one child who's old enough to receive vaccines based on the recommendation. He's 6, and yeah, as soon as it was available, he was vaccinated. I think that probably speaks more to anything anything else that will come out of my mouth for sure.
Absolutely. And again, this is like, again, for as much as people have talked about myocarditis, ad nauseum, again, I think it's helpful for people to hear from an actual pediatric cardiologist vaccinating kids. So that's great. Awesome. Thanks so much, Dr. Khoury, for joining us today. And we'll be right back after this message. Welcome back. I'm so happy to bring on Dr. Robert Leeper. He's an assistant professor of the Department of Surgery and Critical Care Medicine at Western Ontario. Thanks, Rob, for joining us today.
Happy to, Mario. Good to see you.
So we chatted a while about having you on, and I thought this would be a good time because so much of the news right now is focused on mandates and protests and vaccines. And I almost feel like we're forgetting a little bit about why we're doing all this and kind of what the focus is. And
Sure.
Really, we want to prevent serious illness and keep hospitals functioning. So I thought it'd be a good time to bring you on and kind of get a sense of what's going on in the ICUs right now. So I'll start with the question, today's February 11th. Obviously, things change week to week, it seems. But what's your experience right now, and what are you seeing in our ICUs when it comes to COVID?
Yeah, so I work at the Victoria Hospital site, our ICU at Vic, and we are busy, but not crazy. Our craziest time probably was spring of 2021 before we had widespread vaccines, and it was a really tough time with that wave. This wave has been really big numbers. We're probably about a third of our patients in the ICU are COVID on an average day. It was more like half a few weeks ago. So we're sort of seeing numbers come down finally. But what we're kind of expecting and preparing for and dealing with now is a longer tail. Even though the numbers are coming down, the people who are in the ICU tend to stay a long time. If you get COVID and survive, it's a long haul to get off the ventilator and to be back up to the ward. So we're sort of thinking it'll probably be elevated numbers and still dealing with kind of the after effects, the echoes of this current COVID wave, probably through into the spring, and we'll really get a full break till the summer.
We've heard a lot, a number of people ask the question, how many of the people in the ICU are incidental diagnosis versus in there because of their COVID? And what can you say about what's happening in the hospital right now?
Yeah, I mean, as a disclaimer, I'm a very poor epidemiologist. But what I would say is we have loads of people who are incidentally COVID positive, loads, and people who are, and now with the big pandemic, the big current, I guess, issue is people who are COVID indeterminate because they've had it in the last month or two, but never could get a PCR test, and so they're testing sort of semi-positive weeks later. But truly, when I make rounds in the ICU, if we have 30 beds, I think between 8 and 10 are true bill COVID-related critical illness at a given time right now, and a few weeks ago it was half. So that's our experience here.
And again, I'll put your epidemiology hat on here too. What have you seen in terms of proportion vaccinated, unvaccinated, in terms of those who you've seen come through in the last month or something?
Yeah, I mean, so in terms of just the numbers, right? We're seeing more people with vaccines nowadays because the vast majority of the population are vaccinated. The pool of people available to get sick is so much bigger with vaccines. But I have to be as clear and straightforward as I can about this. Since last spring, when we had that bad wave before vaccines were widely available, since the public has had the opportunity to be widely vaccinated, I have not provided care for an immunocompetent vaccinated patient in the ICU. Not. Like, they don't, of course they exist. Of course, there are people whose vaccine didn't work for, but the degree of protection offered against critical illness by vaccination is, to my lived experience, and just one guy working in ICU, it's massive. We almost exclusively care for those who are either unvaccinated by choice or because they had a kidney transplant and just got a big dose of thymoglobulin and therefore their vaccine didn't do anything. Or they are on their third round of chemo for multiple myeloma and their vaccine didn't do anything. Like, those patients are still vaccinated but are not immune competent. That's the only people we see in the ICU, really and truly. It's exceptionally rare to be a fully vaccinated and immune competent person in our ICU.
And that's incredible to hear. This is a center the size of London. Like, in your experience in the ICU, to have not seen that since you have been the vaccinations is truly incredible. What are you seeing again this wave? You kind of touched on that spring 2021 was probably the worst time. Omicron wave, late December, early January. What have you seen in terms of, like, patients are less, well, obviously in the ICU, so we're going to get to a certain level of illness, but shorter duration stay in the ICU, or any patterns you're seeing there?
Yeah, it's interesting, Mario. I would say no. Like, it does. Our experience in the ICU doesn't feel different than previously, which is funny because so many more people are obviously getting it in the community, and being a person who lives in the community, I know lots and lots of people who are getting it, right? Certainly, we're seeing more hospitalization, more incidental diagnosis of COVID, but the people who really have it and have come to the ICU sick with it, they tend to be, because again, that's a very select population. They're the ones who truly are on a ventilator, desperately ill with it. They have the same protracted long course as our previous waves COVIDs, and actually they're not that dissimilar from a standard ARDS patient. You know what I mean? Like, it's when they hit the point of true bill severe diffuse alveolar damage, you're kind of plugged into a long pathway regardless of how you got there, be it Omicron, Delta, or aspiration pneumonia.
Morale in the ICU. Obviously, this is a concern in 2 years of kind of this dragging on. What are you sensing in the ICU morale with staff? Yeah,
it's so hard to pick the one topic that's most concerning me, but that's in the discussion. I hate to see it because, yeah, sure, my colleagues on the physician side of the house, get down and out about this stuff. I feel even more strongly from my colleagues on the nursing side of the house and allied health. They are really bearing the brunt of this, and it's heartbreaking and gut wrenching and stuff to see what they're going through right now, today, 2 years on. It's probably, again, I don't want to use sort of like superlative or severe language, but it might be one of the worst things about this pandemic from the point of view of your friendly neighbor ICU doc. I really am disheartened by the number of senior nurses who retired, the number of junior nurses who are stressed out and suffering with this. It's not to play the world's smallest violin, but it's a very sad thing in our community, our culture of care.
I've heard some argue, when it comes to, obviously ICU and hospital capacity has been one of the limiting factors and what's kind of motivated some of our restrictions to date. And the argument made by some that, well, why couldn't we just have more ICU capacity for just in case for a pandemic like this? I know the answer to that. I just want to hear it from someone who actually works in the ICU. What would be your answer to that, and why we can't flick a dial and change ICU capacity?
Yeah, I think the answer to all your questions is money. At the end of the day, money and human resources are a limited resource. We don't have an infinite amount of nurses. We don't have an infinite amount of revenue to generate or inflate or create to run more ICU beds or more operating rooms. Like, obviously, in the ideal world, if I had a magic wand, I just make the health human resources to run operating rooms all day and all night and ICUs till the cows come home. But the people who are smarter than me or have at least, if they're not smarter, they at least are willing to bear the burden of responsibility to make these choices, have decided that we just, this is how they fund our healthcare system. And, going back to, to Tommy Douglas, like it's a public system, and it's not, you look at Great Britain and the NHS, look at other places with public funded healthcare, it's always just right at the limit of what it can, but the capacity. And that's the way we chose to live our lives. And we should be rightfully proud of it. It's just that it's not, when it gets stretched by a pandemic like this, the shine comes off the apple a bit of the Canadian model of healthcare delivery.
Let's talk a bit about your surgical practice, because apart from your work in the ICU, obviously you're a general surgeon, so a busy surgical practice. How's that been affected by the latest wave?
Yeah, badly in an ongoing fashion, right? I think there are so many sort of profound and difficult to measure long-term effects of this pandemic, and the effect of missed cases, the backlog of cases, and just scheduled surgeries not getting done is going to be really hard to quantify. So many frustrated patients, my poor secretary getting angry calls all the time. It's really hard. And again, I don't mean to be like the world's smallest violin, woe is me. It's not a woe is me thing. I just feel very badly for the patients who aren't getting the care they need. And that I understand why it's happening. I don't like it, but it sucks. No question about it.
So again, back to your ICU kind of experience. So we've heard from, again, a lot of the anti-vax people who are convinced that there is some undercurrent of people who've had serious illness from the COVID vaccine who we just haven't talked about, and people have died. And you're in the ICU. How many COVID vaccine related illnesses have you seen come through your ICU compared to the number of COVID related cases you've seen over the last 2 years?
Well, I can't give you a ratio because you can't divide by zero. Exactly. It's infinity, I guess, is the number, right? Yeah. I think that's how it works. My grade 10 math. Yeah. Exactly.
And again, the thing I push back on is if there's all these vaccine injuries, where are they and why have they not ended up in our ICUs? Because anyone who's worked in the ICU knows that they just haven't seen these type of vaccine injuries.
Yeah, I don't know, Mar. My like the people at this point who aren't taking their vaccines, like I don't think they're looking to debate with us about facts. This isn't a facts-based issue. It's a faith-based issue. They've made a belief in their own heart and their own minds about something. And I, at this point, like I don't think that numbers are going to convince them of anything. So I'm I'm very, all my children are vaccinated. My little 7-year-old daughter is vaccinated. Everyone's got vaccines, of course they are. And the numbers and the science backs us up entirely. But I feel badly for the people who are taken in by whatever this sort of zealotry is around anti-vax stances. The majority of them are going to be okay, and that's okay, but it still hurts our society, and there is a very small minority of them who are going to get sick and really suffer and die from this, and that's a huge shame. And it's not really, I don't view it as their fault. It's kind of like the fault of society and Facebook and everything else that's bred this distrust among people, because it's not about, you can't convince them. They don't want the facts. They have no interest in that. They have their mind made up, and it's too bad.
And I know with our viewers, I'm probably preaching to the choir. Anyone who's anti-vax probably stopped watching my show around episode 3. So yeah. One last question. I'll give you the power of to be the Minister of Health. As someone who works in the hospital, what would you hope that the government does over the next year in terms of support for hospitals? Obviously more funding, yes, but anything specific that you hope they commit to get us back to some sense of normalcy in the hospitals?
I wish I had a good idea. Like in a magic world, I'd wave that magic wand and make more work time and more ICUs. But since I can't, what could the Minister of Health do for our hospitals? Maybe just increasingly taking a rational approach to what will become a more endemic virus, right? Like not, like do we need to have everyone that comes to the hospital doors screened up and down, left, right, and center? Do we need to be super restrictive about where we eat lunch in the cafeteria? I don't know. I think maybe in year 3 of this, we get a little bit more reasonable about, if you're sick, don't come to work, get a vaccine and wear a mask. These are all simple things you can do to help the world, but let's just maybe relax a little bit about the kind of, done for optics restrictions and sort of sillier things that we've come to adopt and accept through the first 2 years of this virus.
Completely wise words, and yes, I will vote for yes. Thanks so much, Dr. Leeper, for joining us.
My pleasure. See ya.
Thanks again to Dr. Khoury and to Dr. Leeper for their fabulous perspectives on COVID and giving us really some food for thought when it comes to what's happening in hospitals. So until next time, stay healthy.